Mack, Michael Gibson, coming to you, talking to you about SAVR versus TAVR in low-risk patients. Tell us what you did, Mike.
So this is the results of the PARTNER 3 trial, which is the balloon expandable valve SAPIEN 3 versus surgery. 1,000 patients were randomized between the two arms. The results were initially, primary endpoint was at 1 year, and the results were initially presented then and published in the New England Journal in 2019. And that showed that TAVR was superior to surgery. We subsequently did one more follow-up at 2 years, and this is now the 5-year results. And so the 5-year results, we had two co-primary endpoints of the trial. The first was a composite of death, stroke, and repeat rehospitalization. And the second was a win ratio of death, disabling stroke, and rehospitalization.
What do you find?
Well, what we found is that the results were similar in both arms. The previous advantages of TAVR had attenuated by 5 years. There was still numerically a benefit to TAVR in the composite endpoint, but was not statistically significant. And it was driven mainly by rehospitalization, which occurred within the first 6 months of surgery, and everything was parallel after that. Stroke and repeat hospitalization were identical at 5 years. The win ratio also was not significant. The win ratio was 1.17, and again, driven almost totally by repeat hospitalization. There was a slight mortality benefit there from surgery compared to TAVR, but it was a minimal benefit. The mortality at 5 years was 10% with TAVR and 8.2% with surgery.
So are there any subgroups, though, that stuck out, Michael, where, one strategy would do better than another?
No, we looked at that in detail, and all pre-specified subgroups, there was absolutely no particular single group that would benefit one versus the other that would help inform the clinician. So unfortunately, no, the results were uniform and homogeneous across all subgroups.
We're talking about devices from 5 years ago. Have there been any technical advances over on the TAVR side that might change things? I mean, should we ask this question again?
Well, in this particular device, there have been, minor improvements in terms of delivery, and there is another generation that is now in trials at the current time, and there are multiple other devices out there that continue to be in trials. But I think that these results are pretty darn relevant to practice today. Any changes are mainly iterative, and I wouldn't expect to have results of death, stroke, rehospitalization to be substantially different. So I think these even though these patients completed enrollment 5 years ago, I think they are highly relevant to today.
Well, it's good when patients have a couple of choices, right?
Yeah, and I think that's the way to approach it. Is you've got two choices with great outcomes from either. And of course, when you have two therapies and one's less invasive than another, the default decision making is to go to the least invasive treatment. And therefore, similar results, patients will tend to understandably and appropriately choose TAVR. On the other hand, if for any reason there are anatomical issues, or other reasons that TAVR becomes high risk, nobody should feel bad about getting surgery here. I think we did a couple of analyses that If we look at a couple things about being alive and well being defined as KCCQ 75 or greater at 5 years, it was 71% with both, so which is pretty remarkable. And then we also looked at being
Mike, can I
alive.
say, I do think that's a great thing. I mean, people want to be alive, they want to
Mhm.
be out of the hospital, and they want to feel well, right? So that's a great composite kind of number that you put there.
The other composite that we did was alive with a durable valve. And
Mm,
you've got an 87% chance with either therapy of being alive and having your valve still functioning at 5 years. Again, which is pretty remarkable.
yeah. Always a pleasure to chat with you, Michael. Appreciate you giving us this update, and thanks to all of you in the audience for joining us.
Thanks, Mike. Appreciate you having me.